We therefore always assess the risk of harm such that those we put into our programs needed to have treated mental illness, not untreated mental illness, and they could not be in crisis to benefit from our programs either. So we did consider biopsychosocial assessments before including them in our programs if there were flags that weren't noted by those who were enrolling people. We also devised the MBCPM program to be more trauma sensitive and trauma informed because the patients needed that. And so we were acquiring that insight. But we didn't even know the terms trauma sensitive, trauma informed back in those days. We instinctively began with shorter meditations. Movement practices really helped if flashbacks were occurring. The body scan was very triggering and really couldn't be used in the initial classes like it was traditionally in MBSR and MBCT. And very importantly, we needed to give a little warning to patients about the fact that meditation practices as we were guiding them might not always result in what they were hoping for, which was more tranquility and equanimity, but sometimes could agitate. And if we were able to do some warning and some ensuring they knew how long a meditation was going to last, giving permission for the positions that were comfortable, etc., then we were more likely to work with patients that were accepting of the entire program as they worked through it. We were able to ensure that those who didn't have a good experience in some meditations didn't hear others who did and think that they had failed. So it was really important to do that, to conduct the meditations in a practiced way, and post-practice to do inquiry at a gentle level so that we weren't forcing people into their insights, but were gentling them into the insights that could be helpful and giving them permission to just dip their toe in the water. And very often they could gradually self-help and self-soothe and get the most out of these practices. Indeed, I would say that those who haven't been through mindfulness programs, if they are going into just a straight meditation lunch hour at work, the longer practices can actually bring up insights and agitation that really needs to be held by a skilled facilitator. So I generally recommend short practices if you're doing just a lunchtime sort of drop-in meditation practice. In addition, facilitators, we felt, must have a personal mindfulness practice that's very accepted, be well trained with a professional training that's not too cheap and sort of rapid, be mentored, hold the space competently, and emphasize the need for individual therapy for those participants for whom a lot has come up quickly and maybe they can't continue on with the program, or they need to go to a therapist before they can rejoin. And also we need to, as facilitators, recognize when we shouldn't be advising to continue practice when those intensities arise, and we should be promoting the use of individual therapists at those times. So there was a lot to learn. And indeed, in the UK, they developed a mindfulness-based intervention teaching assessment criteria document, a big document that we flag to those who train with us, and has 6 domains that we aspire to achieve eventually as we experience facilitating and become more competent in providing these programs. And they also recognized, that group originated this, but they reached across the Atlantic with the authors. They also recognized that after a lot of evidence-based work had been done to show that mindfulness was very effective, that there will be many adaptations of mindfulness programs aimed at different populations. So they published recently on how, why, when to adapt, and what the explicit components need to be to still be called a mindfulness-based intervention.